Good morning, everyone. Hereby, I open this academic ceremony in which Manon Beuque will defend the academic thesis combining deep learning and radiomics-based machine learning to optimize prediction on medical images. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you. Dear Prorector, dear members of the Corona, dear colleagues, family and friends, dear online viewers, thank you for being here for the defense of my thesis. I will now present you my work on combining deep learning and radiomics-based machine learning to optimize predictions on medical images. So first, a bit of background about what is cancer. As you might know, the human body contains billions of cells. Millions of times a day, cells die and are replaced with new cells. Cancer starts when some cells in the body become abnormal and begin to outnumber normal cells in the area. Those cells live for a longer time, they grow and they divide faster. Cancer can also spread to surrounding tissue and travel throughout the body through blood vessel and lymphatic vessel. And then it's a phenomenon called metastasis. And if the cancer spreads throughout the body, then the patient dies. Cancer is the second leading cause of death. In 2018, it was 9.6 million deaths throughout the world. So, cancer can take many forms and invade any organ, making the disease highly diverse, requiring multiple diagnostic tools and treatment strategy. For almost 200 years, clinicians have worked with medical imaging to diagnose and treat patients with cancer. But so what is medical images? And why do doctors need them? So, a radiology image, we distinguish two types of medical image. First, radiological images, which are showing you the inside of the bones, organs, etc. In this thesis, we focused on breast images and brain images. We also have histopathological images, which are tissue which is color stained, and you can see at the cell level, looking through a microscope, you can analyze the image and see if anything is abnormal. So medical images are needed for diagnosis, treatment, to monitor disease, and to prevent future disease. So how do medical imaging interact with cancer patient pathway, treatment pathway? So first, you can have some screening programs. So as you might know, there are some screening programs in place in a lot of countries to, for instance, spot breast cancer. And so all the population at risk is coming to take a mammography image, which is a type of radiology image, to see if there is some suspicious lesion in the breast. If something is found during screening, then the patient is called for further examination, and those examinations are done through radiology images and histopathology image to make a further diagnosis. It's also possible that the patient is being told by a general practitioner to go to the hospital if they have other complaints and need some assessment through medical images. After diagnosis, this is the staging which is happening. So the clinicians want to know what is the extent of the disease. So where is the cancer located in the patient, and if we can find tumor at other location. And this is an important phase because this helps us determine what is best course of treatment. So during treatment, it's possible that a patient would go through again some radiology image being taken to assess which part of the body requires treatment with radiation. And once the treatment is effective and the patient is cured or the cancer is gone, then we still need to have an extra follow-up step because we want to check whether or not the cancer has come back. And so what we think is that where there is medical image, there can be use of machine learning or deep learning to help the doctor in his tasks. So in our thesis, we saw multiple medical images, multiple locations, And we split the thesis in two parts, one which was comparing and combining deep learning and omics-based models, and the other one using feature-based model to augment deep learning prediction. And to illustrate this thesis, this presentation, we took the example given chapter 6, which are images of the breast with contrast-enhanced mammography images. So now, why do we need to think about using artificial intelligence in the hospital? So in 2020, it was 18 million people who got diagnosed with cancer in the world. So it represents already a quite large amount of patients which need to be taken care of by doctors. We estimate that in 2040, the number of patients with cancer will increase to 20 million people, which is a 50% increase compared to 2020. So now, how do we tackle this? One of the solutions would be to have more doctors to treat more patients. The issue with that is that we already are lacking clinicians, and so we think that instead of adding more clinicians, we need better tools to help clinicians already with their workload. And that's where we think that using artificial intelligence to support routine work of doctors can help to treat more patients, to treat patients faster, and treat them better. So now what do we mean by artificial intelligence, and how do we teach a computer to learn to classify an image? So here, let's say that you want to teach your computer to distinguish between images of cats and images of dogs. And you have a lot of images of cats, a lot of images of dogs. You give it to your computer, and it will start learning some pattern. Like it will learn that cats have maybe pointy ears, dogs have a white nose, things like that, which help distinguish between both. Once this is done, the idea is that you can give your computer, again, an image of a cat and an image of a dog, without telling it which one is which, and it will tell you which image is a dog, which image is a cat. So now, taking our example of contrast-enhanced mammography, here we want to know which breast is healthy and which breast is not healthy. So there is two ways to go at it. We can already give the computer some clues. So we already know that, for instance, maybe the shape, the color, the size of the tumor might be a prognosis, or might be of help to train a computer. And so we have already those predefined features that we use to teach our algorithm, our computer, and it will tell us which breast is non-healthy and which breast is healthy. Another way to go at it is to already give the images directly to the computer without any predefined features. So then all steps are included in the model, and the computer tells us which breast is healthy, which breast is non-healthy. So now you might think that using deep learning seems easier because we don't need to predefine any feature. We just have to give the image to the computer, and it will give us a classification. The bottleneck that we have with medical images is that it's not really clear which of the two methods gives us a better performance. So we don't know necessarily which technique to adopt. So the idea of this thesis is simple, is that we want to see if we add both techniques, we can obtain a better performance. So that leads us to the hypothesis, which is that feature-based machine learning and deep learning captures information from medical images, which is complementary, and their combined use results in more accurate classification prediction. So first experiment was to compare and combine deep learning and feature-based machine learning. So the idea was to basically use the two models that were described before in parallel. So we take the raw data, we preprocess it especially for handcrafted radiomics, then we do feature selection, machine learning, so we train, test, evaluate the model, and we look at the result. In parallel, we also process the image for deep learning use. We put it in a deep learning pipeline, which is training, testing, evaluating the model, and then we look at the result. And at this stage, we can combine the result of our two models. So we can maybe average the result or look at the consensus, so when both of them agree together. So for our study case here, we want to know if the mass that we see in the image malignant. So here we have contour, which was already done by a radiologist, which spotted a suspicious lesion in the breast. So first, we want to extract from the mass delineated here the radiomics feature. And once this is done, let's say we already have an algorithm which is trained, the computer tells us that the mass is malignant. Now we preprocess again the image, this time for deep learning use. Let's say again that we have a model which is already trained. It tells us that the mass is malignant. And so when we compare the results, we have a consensus, both models agree, so we can confidently say that the mass is malignant. Now in a second experiment, we use feature-based model to augment deep learning prediction. So we took the same steps than in the first experiment, but this time we do them sequentially. So we take the raw data, which we use to train a deep learning pipeline, and then we look at full uncrafted feature-based machine learning pipeline on top of our deep learning pipeline, and we look at the combination of the results. So now if we take our study case again, here we have another question, which is where is the mass of interest, and is it a malignant mass? So this time we don't have the delineation made by radiologists, and we want to know where is the mass of interest. So we preprocess our images for deep learning use, and our deep learning model tells us that it spotted 3 masses, and it also gave a classification. So it predicts here that the first mass is malignant, the second that it found is also malignant, and the third one is benign. Now we want to check if this is correct. We want to see if we obtain the same result with a feature-based machine learning model. So what we do is that we take the prediction of our deep learning model and we look at what a radiomics-based machine learning model would tell us. What we see is that for the first case, it also predicts that the mass is malignant. So here we have a consensus, and we would flag this image to a radiologist. For the second one, we can see that we don't reach a consensus. We don't know if the mass is malignant or benign because both models don't agree. So we would also say we are not really certain about this label. This might be malignant or benign. We would say that to a radiologist. And for the third one, it was predicted benign. So because then it's not a lesion of interest, because we don't think this is going to be an issue for the patient, we can discard this finding. So to conclude, we have shown in this thesis for the first time the potential of utilizing the strength of uncrafted feature-based models in combination with strength of deep learning models for multiple medical imaging datasets and diverse tasks. Our results are promising and offer insight into a new avenue of research, but validation of our findings in independent series is still required. Thank you for your attention, and I give the floor back to the prorector.
Thank you for this interesting presentation. The opposition will be opened by Professor Kessely, Professor of Gastroenterology at the Maastricht University Medical Center.
Thank you, Ms. Prorector. Dear candidate, first of all, let me congratulate you with this excellent piece of work, which is very timely and points to the clinical implications as well as you nicely presented this in this presentation. And congratulations also to your supervisory team for this piece of work. I'd like to start by asking you some more general questions about the clinical applicability of these techniques and what you have found. And what you are actually trying to do is something that everybody wants to do, is predict the future. And there's one thing that is certain about the future, that it is uncertain. So how do we as clinicians deal with the fact that there is still an element of uncertainty, like you just also showed, when the models don't agree, you just cannot know for sure. So how do we actually deal with that in clinical practice?
Highly esteemed opponent, thank you for your kind words and your question. So in terms of uncertainty, yeah, it's difficult indeed to predict the future, but I would think that we only tried this in chapter 4, where we use brain MRI images, because else we are trying to see on the image what radiologists already can see. And so in that sense, I don't think we are predicting the future. We are trying to read the image as a clinician would do. So I think for classification on medical images, this would be more trying to see what the radiologist already see and not really trying to predict something which is not seen.
Yeah, okay. So I also refer to, with predicting the future, to predicting progression, for instance, from Barrett's esophagus to cancer. But I perfectly agree with you. So the thing that concerns me a bit as a clinician, if you look on page 130 in chapter 5, you discuss about the lymph nodes, detecting the lymph nodes and the potential cancer cells in the lymph nodes, but in 9% of the cases, the system, so to speak, doesn't even detect that it is a lymph node at all. So that's something that when you refer to trustworthiness of AI, which is something you discuss in your general discussion, I am a bit puzzled about the trustworthiness when even the basic recognition of a lymph node appears to be uncertain.
Yes, I agree with you here. I think we can't put this model in the clinic if it doesn't, if it's not able to see 100% of the lymph node. So yes, the idea would be to aim for 100% recall.
But that is impossible. You're not going to get to 100% certainty, I assume.
Well, it depends where you put your threshold, because you could flag all your images as containing lymph node, and then you would reach 100% recall, but that's not very interesting, because then you also have a lot of false positive finding. But I agree with you that it needs to be flagged when a model can or cannot assess an image, and that's an area which needs to be further explored, because you don't want to give an image to a model and it predicts something, but actually it shouldn't have predicted anything because it never saw this kind of data before.
So let's assume that your model's performance is the best possible, and let's assume that you've convinced all the doctors to actually use it and it's trustworthy. If I go back to the hospital this afternoon, what do we actually need to do to have this system or model implemented in clinical practice? What are the necessary steps for that? Who do we need to convince? Is it the board of directors? Is it the IT people? What is your recommendation in that?
So I think for lymph node finding, we can already flag that probably the model don't spot everything, but it can already help segmenting lymph node and can already be of use in a sense, because this is semi-automatic, let's say. So if we say that it doesn't see everything, but it can still be of help, it's still better, in my opinion, to use it to gain some time rather than not using anything and doing everything by hand.
Yeah, and I perfectly agree with you, but how do we actually go about using this system in clinical practice? So do we need a software application that will be coupled to the electronic patient dossier? Is this a separate server that we need to use to actually be able to implement this in practice?
Yeah, I think for having it in practice, you will probably need the help of a company to do that, which will be there to assist and also have a look at how the model performs in the clinical setting, because clinical setting can be quite different compared to what was shown in a study. You can install something like continual learning, which was presented, for instance, in Nature Communication by Beuque et al., which is basically detecting pseudo-domains. So the idea is that if it's a spot that there is a data shift compared to what it was trained on, then the model can retrain, or it can be flagged to the clinician which is using the model.
Okay, thank you. Well, if I may one last question, Mr. Prorector, is that allowed? Thank you. So this is related to chapter 3, because you're talking about the research setting or the setting which you have worked in versus the clinical setting, and that might be the same. So chapter 3, you looked at Barrett's esophagus, And if I read correctly, you had 57 biopsies from 57 patients. This is something you say on page 56. It would have been even better if it were on page 57, but this on the page before. Anyway, so does that mean that you had one biopsy from one patient? Because 57 biopsies, 57 patients, is that the case, or was it differently distributed? The reason I'm asking is because in clinical practice, we always take at least 4 biopsies from one level, and the longer your Barrett segment is, the more biopsies we take. And the reason for that is because there's sampling error. So is that something that could impact your model's performance in this setting?
Yes, certainly. I think that, yes, we had 57 biopsy for 57 patients, and only one was selected for mass spectrometry imaging. So we had, I believe, like one sample per patient. And indeed, that would be a limitation if we need actually more biopsies to assess, but I believe it's quite time-consuming to do mass spectrometry.
Yeah, and on which basis did you select that one single biopsy? Was it at random, or was it based on histological characteristics that the pathologist determined, or was it just at random?
That's a good question. I think it was not random, but this was my actually co-author who selected the biopsies. So.
Okay, I perfectly understand that you're working in a team, but I think this is something that you should take into consideration for future applications. Thank you, and I will give you the word back to the prorector.
Thank you. The opposition will be continued by Professor Kater, Professor of Clinical Artificial Intelligence, University of Dresden. Thank you for joining this meeting from a distance. Professor Kater, the floor is yours.
Thank you so much. Thank you so much, Prorector. Thank you so much to the candidate for her very, very nice presentation. I'm sorry I cannot be there in person, but I'm glad I can join here via Zoom. So I'm Professor of Computer Science and Medicine at Technical University Dresden, and I have a few. First of all, let me congratulate the candidate, please, for this very, very nice thesis and the very, very nice comprehensive presentation. I have a few maybe more general technical questions. One thing that you mentioned is that we should always perform external validation for our machine learning systems in medicine. Can you give me some reasons why we should do this external validation?
Highly esteemed opponent, thank you for your kind words and your question. I think, I'm not sure I heard correctly, but you're asking if we need to do external validation for all the...
Yes.
Okay. Yes, so I believe that indeed external validation is necessary if we want to prove the generalizability of our model in other clinical setting. Yes, it depends what is the aim of the model. If we want to keep the model, let's say, within the same clinical setting, within the same hospital, then probably it's not useful to take to externally validate our results.
Okay, thank you very much. Another question that I have is that I noticed that you use the area under the curve as one of your evaluation metrics for the machine learning models. Can you explain why did you choose this as your statistical endpoints, and what are maybe the pros and cons of the AUC and maybe other alternatives?
So we choose AUC because it felt like it's the most global metrics that we can report. So it reports, it's balancing sensitivity and specificity. But yeah, it doesn't necessarily give a good idea of how what kind of result we can expect in a clinical setting. So we also reported different other metrics to make it a bit more transparent. So I believe every time we reported sensitivity, specificity, and balance accuracy sometime to give as many information as possible regarding performance of our model.
Thank you very much. And yes, indeed, that is something that I noticed quite positively in your thesis, that you indeed use a number of different metrics to judge the model performance and not just one single metric. Yeah, very good. Okay, I have another question regarding an important concept in machine learning, so overfitting. Can you briefly explain what is overfitting and which approach is more at risk for overfitting? Is it the classical radiomics approach, or is it the deep learning approach, which has usually more overfitting?
Yes, so the idea with overfitting is that the model will be fitting too much on the training data that it saw, and basically instead of learning a classifier, it will learn to recognize the training data set, and when we test it externally or on test data sets, then we can see poor performance or statistical different results between both curves, performance on training and testing. I don't think that there is necessarily better method for radiomics machine learning based model or deep learning based model. I think it's more about how you tune your model that will matter. You can use cross-validation in both cases to make sure that your model don't overfit. And it's also good to balance your training data to not have too many, a class which would be overrepresented, and to avoid overfitting on this class.
Thank you very much. Yeah, I agree. And these are very important considerations. And when you design a machine learning experiment like you did. I have another question regarding the deep learning approach. What you showed is that the deep learning approach requires more data than the classical radiomics, right? So it's more data hungry. Let's say we want to stick to the deep learning approach for a given problem. Is there a way to reduce the data requirement? So any, if you have, is there any way how you can make the deep learning approach less data hungry?
So there would be different way to do this. If it's possible to have a lot of data, but we don't necessarily have any label on it, or we have some weak label, we could consider to use some foundation model. For instance, there is a nice paper in radiology presented by Selleren et al., which shows that with supervised contrastive learning, they basically had a bunch of X-ray. They didn't have necessarily the label for those, but they had some noisy label. And by using about 1 million of images and pre-training their models, they could achieve very good performance on a retrained deep learning model using only 50 images, for instance, on more specific tasks. So that would be a possible way to use deep learning with not a lot of data.
Thank you very much. Yeah, that is an excellent response. You mentioned contrastive pre-training as a way to reduce the data requirement, and I agree that is one of the most common methods nowadays. It emerged really in the last couple of months, and this is part of self-supervised learning in general, right? So can you briefly comment on the term self-supervised learning? What does it encompass? How would you define it?
So the idea is that one of those models would be to augment one image, and so it kind of learns a more abstract representation of the image, and the idea is to make it more robust to noise. The idea of self-supervised learning is to learn embeddings which will be more stable and which would not be affected by noise.
Thank you very much. Excellent response. I believe my 7 minutes are over. Dear Pro-Rector, thank you very much. And I give the word back to the Commission.
Thank you, Professor Kater. The opposition will be continued by Professor Niese, Professor of Biomedical Imaging and Dean at the University Medical Center in Groningen. So thank you for joining us.
Thank you, Mr. Pro-Rector. Dear candidate, first I would like to also congratulate you with this beautiful work, very impressive. Also would like to compliment her and congratulate your supervisory team. So I would like to ask on the chapter which contains prediction, chapter 4. So it's a very impressive piece of work in which you utilize large data sets to compare different approaches, radiomics, deep learning, and a combination of both. And I'm just wondering to what extent what we're doing in this field is still a bit of an art or a science. It's really trying to figure out which combination works best, is best generalizable, has the best performance, and through extensive series of experiments, you get some tangible results to address that question for this application. Still, I had a few questions that I would like to ask you about this. The first is, do I understand correctly that if we would compare the radiomics approach with the deep learning approach, that essentially you augment the radiomics features with the last layer of your neural network? So you have a larger set of features, but you still have all the features of the conventional radiomics model going into making the radiomics classifier.
Highly esteemed opponent, thank you for your kind words and your question. So indeed, what we did in chapter 4 was we wanted to predict radionecrosis based on MRI of the brain. And so what we did is that we combined at final stage when we assembled deep learning and radiomics model, we combined the deep learning features extracted from the last layer of the deep learning model with radiomics features, and it gave better results to assemble both. So yes, we took the deep learning and the radiomics features and we did some feature selection on it, and we trained a model like we would do with a classic radiomic approach.
Yeah, so the thing that puzzled me in the results is that I think you with the feature selection you select 20 features from the radiomics classifier and 10 features from the combined. So I was wondering whether there was a logical result. Did you expect that you, with a larger set of potential features in the radiomics models, you select fewer in the final model?
Well, we used some regular feature selection method, I believe, and so what we just looked at, we didn't try to take the same number of features. We used the features, the number of features which was most relevant, and so I don't really know probably if we only selected 10 features for the final prediction, then it was probably more descriptive more descriptive features than the 20 features that we used to predict our outcome.
Yeah. Okay. Yeah. Clear. So in the end, it is really about empirical optimization, and we have to learn what works best. In that sense, I was wondering, do you have any idea from your experiments whether this comparison between radiomics versus deep learning versus the combination is dependent on the number of images? If you would perform experiments with part of the data sets, or you would increase from 10% to 100% of the data set, we could probably get some insight in how the methods improve with more images. Do you have the feeling that the results would be different if you would double or would halve the data set?
Yes, that's an excellent question, actually. We didn't experiment with that. I think for all our experiments, we had a range of 500 to maybe 1,500 images. So the range was quite similar, but we didn't experiment. We didn't try to only take 10% of our data set and see if radiomics or deep learning would perform better, and when we would see the shift between both methods. But that would be indeed a good study to do.
Okay, and I think one strength of your thesis is, or of this chapter specifically, is that you also validate on a fully external data set. If you look critically at the literature, very few studies actually do this. So everyone's doing cross-validation, but still they're validating on the same data set, and it's really important to validate on an external data set to know how these methods will really work in clinical practice. So I was wondering, you indicate that is a strength, but also you've only one data set, and also in your presentation you gave, you alluded to the fact that you would need to validate in more settings. So how do you think as a field we should move forward? Because I think this is like a general limitation in the domain that we do too few external validations. So do you have some advice for us as a community how we could proceed in order to increase the generalizability and really know how we can validate the generalizability?
Yeah, so I think there are different ways to do this. It can be interesting to do a multi-center study and compare the result in different centers, or compare the result of the model. And if we see some discrepancy between the results we obtain and the results we expect, it's good to analyze what is the difference in the images. Is it the patient population which is sampled differently, or is it the acquisition parameters which are different? In my opinion, it needs to be clear in which setting the models should be used, which acquisition parameter with which population sample can we expect the model to perform well on. And so, yeah, it would require then either maybe a prospective study or multi-center retrospective study, or maybe prospective study in multi-center. Yeah, just to see what is the limit of the models that we're building.
Okay, thank you very much for your answers, and I give the word back to the rector.
Thank you, Professor Niesse, for your contribution. The opposition will be continued by Professor Smit, Professor of Surgical Oncology at the Maastricht University of Medical Center.
Dear candidate, first of all, congratulations on this beautiful thesis to you and the team, because it's always teamwork. And I feel honored to be here today to discuss with you on topics we both find interesting. Obviously, since my topic is breast cancer surgery, chapter 6 was my favorite. And I wonder, how do you think this chapter 6 is going to change clinical practice?
Highly esteemed opponent, thank you for your kind words and your question. So for chapter 6, what we showed was that we can perform good results using a combination of deep learning and radiomics on contrast-enhanced mammography. And so I think it could be maybe compared in a sense with what we see now in the clinical trials that was put in place for mammography by Lang et al., which was published in Lancet, where they use it as a second reader in a prospective study. So I think we could expect something like that, and that this model could be used as a second reader, a second radiologist, and could help also with triage. So we could have a deep learning model running, or deep learning and radiomics model running in the background, and flagging already which patients are maybe at most risk, and display those first to radiologists.
Yeah, but the thing is that in clinical practice, there's one radiologist having a look at all the images. in the hospital. So how is this gonna add up?
Well, then we can imagine that it could be as triage, used as triage, and because when the radiologist starts his shift, he would not know which patient to look at first, which images to look at first. So maybe we could just rank the images that were seen by the model in terms of gravity, and flag them to the radiologist.
Okay, and if you could travel back in time, would you have changed something in this study design?
Well, I think it would have been nice to also maybe acquire some FFDM images, digital mammography, but yeah, I don't know how feasible that would have been actually, to actually also include the classification on top of our model, because right now this is a big gap in our model. We're not able to spot calcification, malignant calcification in our contrast image.
Okay, malignant calcifications are also very difficult for radiologists. That's why they take a lot of biopsies. In the current model, you have about 300 malignancies in over 1,000 patients. How many calcifications should have been included to have a really good model? Because I think 300 malignancies, of which maybe 10% calcifications, is not enough. How big should this group be?
Yes, so currently my team is working on making more data, so making more calcification, more malignant calcification, and so artificially create those images to train deep learning model to detect those calcification. But we also know that on contrast-enhanced mammography, those calcifications don't enhance. So then we don't need. Contrast-enhanced mammography doesn't help with spotting malignant calcification.
Okay, and what kind of group are you using for that model? Because not the contrast-enhanced.
So we have in contrast-enhanced mammography low energy and recombined image, or high energy, which is basically then used for recombined image. So I believe what is used is a low energy image, which is comparable to digital mammography.
Yeah, really interesting. And still traveling a little bit back in time, would it have been worthwhile to include as a third study arm the radiologist, him or herself? Like, what is the added value?
So to already implement it in the clinic and see if there is an added value, like added time or spotting more.
Or decreasing time for the radiologist.
Yes. Yeah, no, indeed, that would be an interesting study to do further, like if it has any added value. And hopefully we expect to see that then the time of looking at the image would decrease for radiologists, but we don't know that for sure. So it needs to be tested in clinical setting.
Yes, because I was thinking, you started with the aim is the incidence of cancer is growing, is rising. How are we going to help clinicians in all this tumor load, this cancer load? What are the next steps going to be to get this model to really help the clinic? You're talking about calcifications are difficult. What steps else do we need to take? What if you had $1 million crypto? It's even more worthwhile. Yeah.
Well, yeah, it would be to test it in the clinical setting and do a big prospective study and assess, are we actually gaining time using this kind of model? But also, this is not necessarily clear how radiologists would want to use it. So we need to go to the radiologist and basically say, okay, what do you find most useful? What do you want to see? Do you want things to be flagged? Do you want something already prepared with, I don't know, already the diagnosis and the report set. I'm not sure. I think this needs to be assessed with multiple radiologists.
Thank you for your answers. Now giving the word back.
Thank you. The opposition will be continued by Dr. Wind, postdoc at the Department of Precision Medicine, University Maastricht.
Thank you, Mr. Pro-Rector. Dear candidate, I would like to join the rest of the committee members in congratulating you and your supervisors with this comprehensive and nicely written thesis. I read your thesis with great interest, and being somebody that's interested in patient participation, I was very happy to see that your thesis mentions the word patient no less than 380 times. So my heart jumped and I was like, yes, finally, read something about patients. However, not once did this actually concern or reflect the opinion of patients themselves. And why is this important? Well, with many diseases, but especially with cancer, patients often feel out of control. Now, what you developed seemed mainly to aim to help doctors manage patients better, to make better choices for the patient. And to me, this suggests that the patient, again, here is the passive object instead of the one being in control. And this brings me to my question. To what extent did you involve patients in your research, not only their imaging, but also their voices and their opinions? And if not, why not? And shouldn't it be nothing about me without me?
Esteemed opponent, thank you for your kind word and your question. Yes, that's a that's a very good question. So no patient was included indeed in my research, and I think that would be a field of topic to definitely study, because obviously patients have also ownership of their data, and they should be able to know how it's being used and for what purpose. But also, I think we saw recently with the rise of ChatGPT and other deep learning model which made the news, that the general population is also very concerned about how it's being used and what it can do, and the fact that it's also a black box is is raising concern. So indeed, I think there should be study done to make the patient aware of how the data is being used, for what purpose, and how it can help the clinician to diagnose their cancer better. And yeah, but I didn't do that.
And how would you propose to do that? Because I read in your thesis that it helps doctors manage the patient. So and indeed, it seems a bit like you would also like to use these algorithms to, I don't know, make treatment choices or at least support treatment choices. But I think, in my opinion, the choice should also be always be the patient's choice in what the treatment will be ultimately. And you said before that you would like to talk to radiologists to see what they need and what they would like to do. And one of your propositions is actually we should ask doctors, what do they need, and we can develop that for them. But shouldn't you also talk to patients and be a bit like, well, what can I do for you? And how do you propose your field should involve patients more in that kind of research?
So I'm not sure how we can involve patient exactly. I'm not sure where the patients are already on what base the diagnosis is made. If they know what the histopathology images looks like, and what was the assessment exactly of the clinician for their cases. It would be of interest to be able to provide material to explain the patient how things were assessed, but I don't know if every patient would also be interested to know exactly what is the technical background and how the diagnosis was made, etc.
But you do feel there should be a bigger role for patients in this type of research, or do you feel like it's aimed at doctors, therefore patients have no role and should just be the recipient of the advice that the doctor can give them, maybe based on the models that you give them?
Well, I believe that if a patient wants to know how a certain diagnosis was posed, what is the staging, and why is there certain treatment which are suggested and other not, that the patient could have access to this information, so to be transparent. But to have it, to give it directly to the patient and say this is what we did, and we used this technology, this technique, and this CT and acquisition parameter, I don't know if that would be very much of interest for the patient. But I believe in transparency, and they should be able to know how a certain diagnosis was posed.
Okay, thank you very much. I would like to give the word back to the pro-rector.
Thank you. The opposition will be continued by Dr. Walls, postdoc at Maastricht Clinic and Grow at the University of Maastricht.
Dear candidate, I would also like to congratulate you and your promotion team on your very nice thesis. I really enjoyed reading it. My first questions are actually about one of your propositions, so I would like to ask one of your paronyms to read proposition 6.
To facilitate the adoption of machine learning models in clinical practice, there is a need to explain how the model works.
Thank you. So indeed, you also show in a number of your chapters feature importance that can explain which features are most important for your machine learning models. And most of the features there are easily interpretable for humans already, right? So clinical features, radiomics features, we know what they mean. We know we can envision something when we see that they are important for the model. But I was actually wondering, what about the deep learning features? Because they are far more abstract, so how can we make those meaningful?
Esteemed opponent, thank you for your kind word and your question. So there is some work being done at the moment, like concept attribution, in a nice paper of Graziani et al., which was published in Computers in Biology and Medicine, which the idea is to extract features from latent space within the deep learning model and to correlate that with semantic features that the clinician would expect to see in the image. And the idea is to make sure that while the model is learning what a clinician would also look at in the image. So that would be a way to go. And the idea is also for it to be complementary to GradCam method. The problem with GradCam method is that even though you know the location where the model learns something, you don't know exactly what it means. So that would be a nice addition to it.
Mm-hmm. Well, you actually mentioned something interesting. You said that we want to make sure that our deep learning models look at the same things that our clinicians look at. Is that really necessary? Like if a model has perfect performance, but you see from the explainability that it looks at very different things in the image than the radiologist, is that a problem?
For now, if we want to make the model trustworthy, I do think it's an issue, yes. Because in the end, for classification purpose, not to predict the future or future outcome, the clinician and the model looks at the same image and they give staging or assessment based on this image. And the model is trying to mimic the same performance than the clinician. So I would say, yes, they need to at least agree for some of it. And I believe you can do then exploration or try to find biomarkers in other studies, new biomarkers. And then they need to enter the clinic and need to be agreed upon. And then, yeah.
So your aim with explainability would really be to make the user trust the model? And how would you present that information in an easy way without overloading the user?
Well, in the ideal world, I would think that then we would present it as a text. So if we can get some natural language model who would basically translate those set of features into words and basically give some kind of radiology report or, well, what a clinician would be used to, that would be ideal. And I think it's reachable if we know which features are being looked at.
Right. You mentioned explainability for classification models, but you also did delineation in your thesis. Is there a need to make that explainable, do you think? And if so, how would you do that?
Well, delineation is quite similar to classification. It's also classifying a set of pixels. So I think that could be the same thing. We could basically use the same strategy to also see what the model looks at and on which features, on which semantic features it is based on.
All right, and I have a few more questions about chapter 5, actually. So there in figure 3, you showed the performance of your method on external validation set. And it seemed that the method you developed seemed to increase the number of false negatives on this external validation set compared to the traditional method. So is that a problem to have more false negatives than false positives? Which one is worse, in your opinion?
Well, to have a false negative is definitely an issue. I think the issue there was that we didn't manage to harmonize the images, actually, to homogenize them. So I think it would be good to go back to the pre-processing step. And there is a paper in, for instance, medical image analysis, which is doing that from Wang et al., where they used some unsupervised Fourier-based data augmentation. And so the idea is to have the same staining on those histopathology images, and I think that would help then, and to have something in place again which would limit the use of the model on images where it can't classify. So to have a way to spot the data set shift compared to training set.
Yeah, because you've very nicely listed all the reasons why the false negatives were false negatives. So how would you use that to optimize your model? You mentioned selection of input data already. Are there other ways that you can use that information?
Yes, that's true. We can indeed look at where it failed, where the false negatives are coming from, and enrich our model with that. So we can use some data augmentation, for instance, to give more of those examples in the model, and maybe balance it more, or just give way more of those difficult cases to the model.
Do you think it's possible to get rid of those false negatives completely?
Well, so again, it depends where you put your threshold. So it's possible, but then if you have a model which only predicts lymph nodes in every images, this is not very useful. So it is possible, I believe, but for that we need to carefully select what images is being given to our model. Yeah.
I also had one more question about the delineations that you did, because you used the UNAT to delineate the lymph nodes, right? And you used the output of that UNAT, the probability map, to extract features from that, if I understood correctly. But for the delineation itself, did you use a threshold on that probability map to get the delineation? It wasn't quite clear to me how you got from the UNAT output to the delineation.
Yes, so I believe we used just a simple threshold of 0.5 to get those delineation, and we also applied extra post-processing step, because, well, we just already know where the background is because it's white background compared to the histopathology slide. So what we can do is correct a little bit those delineation by just including all the tissue which is around the delineation to refine the delineation and have a nicer result.
Because for the classification, you actually propose to not use that 0.5 threshold, but then for the delineation you do use it. So could you think of a way to also personalize or optimize that threshold for the delineation? Is that necessary?
Yeah, I would say it depends of the distribution of your prediction, because it can happen that the model basically only predict 1 or 0. Ideally, you would want it to predict in a range from 0 to 1. So I would say that
Manon Beuque, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room. Manon Beuque, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Lambert is authorized to confer upon you this academic distinction in accordance with Dutch university custom, and I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
Doctoral candidate, by the authority vested in us by the law and in conformity with the decision of the committee here present, I hereby confer upon you, Manon P.L. Beuque, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. We'll now another picture.
No.
Okay, sorry.
Thank you again. I will now give the floor to your co-promoters, Dr. Henry Woodruff.
Thank you very much. I have the honor to give the laudatio today. So ladies and gentlemen, and esteemed colleagues, and most importantly, our graduating students, we're here today to celebrate the completion of a rigorous academic journey, but also to honor the extraordinary individual who's standing here, which is now Dr. Manon Beuque. So I really remember when Manon first walked into our department, she was like every bit the engineer from Paris had envisioned, all the way down to the Doc Martens that she was wearing. And little did we know at that time that those shoes would also be a metaphor for Manon's resilience and grit, and actually that she brought that to our department. She actually joined us when our department was more a concept than a department. We had just been newly formed. The walls had been freshly painted by the PhD students and the postdocs. We had assembled the IKEA furniture ourselves, and I don't remember exactly, but I think you had to assemble your own desk before you got to use it. And those first years were not only about research, but also about creating something new. So in more ways than one, Manon helped build the department really from the ground up. When she arrived in our department, there was this new buzzword, deep learning, that was starting to echo in our field. And we had theories, we had heard about it, but we didn't have the data, we didn't have the expertise in this. So Manon actually found herself in a situation where she had lots of supervisors, Arthur, Benjamin, Philippe, Heike, myself, but none of us really knew a lot about this new and emerging field to guide her in her studies. So necessity did what it usually does best. It became the mother of invention. Manon actually learned a lot by herself about this emerging field. She took deep dives into her projects, and she embraced this multimodal approach of combining different things, something that she remains until today, because she's now also, up to today, been multimodally academic and already doing research in the industry. The beauty of Manon's journey lies partially in her involving a very strong independence. And this independence was first forced upon her in certain ways by the circumstances that were kind of beyond her control. We had the COVID lockdown, which further compelled us to adapt and try different things. And within that chaos, Manon continued to carve her path, sometimes stumbling in the beginning, but even more as she continued, she showed stoic determination, and it actually led all the way down to this momentous conclusion here, which is the conference of her PhD degree. This journey, or most journeys, are rarely undertaken alone. And Manon had many colleagues that became friends, like Abdallah, Ivonka, Janita, Relinde, Sergey, Will, Simon. That became her circle of strength, her circle of friends, and often also travel companions. There was this one Paris trip that I remember very clearly that came back with lots of stories, and I think I can just summarize it as it was very eventful. And I think enough is said in this setting anyway. This close-knit group became her sounding board, her stress relief during the intense moments. And these moments unfortunately involved some very unfriendly emails from industry, which is a chapter that I'm pretty sure you're very happy to close at this moment. Nonetheless, she kept showing her caring side in our department. For example, she became the student representative of all 12 Marie Curie ITM students in her network, in her PREDICT network, something that the other students very much enjoyed having her do. And she also found balance in her life by savoring cheese, as you'd expect, playing board games, cuddling her cat, Lily, who appeared often in Zoom meetings, as cats do. Sometimes Manon wanted it, sometimes not. And of course, spending a lot of time with her partner, Alex, who supported her in this journey. So she really reminded us all that our well-rounded life is not just desirable, but essential for a good researcher. There's a wise proverb in English which says that smooth waters do not make good sailors. And Manon's journey was anything but smooth, and perhaps that was the blessing, because in the end, what was forged was not just a PhD, but an independent, strong, and competent researcher. So today, let us not just celebrate the achievement of the PhD degree, let's celebrate Manon, who reflects the spirit of our department, which is not a straight road, but a bendy journey that still leads to new horizons. So congratulations, Manon. May your future be as remarkable as your journey here. And of course, congratulations to the promotion team, excluding myself. And félicitations à la famille. Vous avez toutes les raisons d'être fiers d'elle. I hope I didn't butcher that too much. Congratulations.
Thank you.
You're done? Yeah? Okay. Thank you. Very nice words, ending in French. Yeah. Dear Dr. Beuque, I also want to congratulate you on behalf of the University of Maastricht with your degree you have acquired. Thank you. I wish to give the floor to Professor Kater for a short congratulations. Professor Kater, the floor is yours.
Thank you very much. First of all, congratulations, Dr. Beuque. This was a really impressive work. I was an international opponent here in this thesis, and I'm doing this quite often for doctoral students in the UK or in Scandinavian countries or the Netherlands. And I think it's really important to have this international perspective to make sure that the science is on the highest levels and can also compete globally. And for your thesis, I'm very, very confident that it's on the highest level globally and can really compete globally. So congratulations again, and I wish you really good celebrations.
Thank you.
Thank you. Professor Nissen.
Yes, I would also like to congratulate you. I was very impressed by the work, by your presentation, and also the defense. You're clearly rising star in the field, and I look forward to what you will do the rest of your career. So I wish you today a very, very nice day and also a very nice career.
Thank you.
Thank you. And hereby I close this session, and we make a little bit of pictures here. If both of you, Professor Kater, Professor Niesel, will be on the screen, you're on the background, and then we make pictures here. We go to the stairs, we make pictures, but the audience can already go to the restaurant for a short drink. Thank you. All right, please.